going to be a great morning, and we really appreciate the diversity of perspectives that are in the room. We have folks from the business community, we have legislators, we have folks from the executive branch. I saw the dean of our College of Medicine. We have a lot of colleagues from the UVM Health Network. We have our trustees from the UVM Health Network. And so again, the diversity of perspectives that we have in the room really speak to the importance of the topic. And we really want to put what we're doing here in Vermont collectively into the national light. We're going to start with some comments from our good governor, Phil Scott. Governor Scott, we very much appreciate the optimism that you expressed in your budget address, and I can speak for our part of the provider community that we're really also very appreciative for the opportunity to work with everybody to move the healthcare agenda forward, because everybody in this room, everybody wants the same thing. We want Vermonters to have access to the highest quality, affordable health care when and where they want it. And we're all working on that. And I think this morning will be great to share ideas and comments on how we get there together collaboratively. So, Governor Phil Scott.
Well, good morning. Thank you, Dr. Brumstead, and thank you all for coming. I know it's an early meeting, an early morning, and it's great to see other people getting up early as well. I wondered where everyone was when I'm going into work early, but we'll have to do this again, maybe tomorrow. I also want to thank Dr. Sharfstein for coming back to Vermont to help us learn about national efforts as well as how we stack up against others. Now, I know we're all working very hard to produce successful outcomes. And I also understand all too well the pressure to do it quickly, given the challenges we face as a state and what we face in healthcare across the platform, across all the population, and especially with our aging population here in Vermont. But I hope one of the takeaways from this morning is that there's some light at the end of this long tunnel. And we highlight some of the things we're doing well here in Vermont, or more specifically, what you in this room are doing well when it comes to care coordination and payment reform. To start the conversation, it's important we recognize where most Vermonters are coming from and to listen to their concerns when it comes to healthcare and healthcare reform. Now, I traveled the state a lot and talked to Vermonters from all walks of life. And what I typically hear on healthcare is how expensive it is, as well as how difficult it is to find a doctor. And because of the 6 years of turmoil over single payer and the incredible challenges with our IT portion of the exchange, there's also deep skepticism across the board when it comes to any major reform initiative, which makes it difficult to talk about what we're doing. So to help set the stage, let's lay out a few facts. We have one of the lowest uninsured rates in the country. We should be proud of that. We're ranked the healthiest state in the nation in 2019 by the United Health Foundation. And Vermonters generally have good access to primary care. But these good things come at a price for Vermont families, and the increasing cost of this success is not sustainable. Now, I recognize this exchange only includes about 75,000 people, but it's the group policymakers most often refer to for discussions around cost. And plans on the exchange are very expensive for many Vermonters, including young Vermonters, which we need to change. We need to make sure that we're drawing them in, but especially if they don't qualify for any subsidies. For example, a family of 4 with a silver plan, it costs as much as a new Subaru Crosstrek every single year for their insurance. So as governor, I want to make sure that we're maintaining and improving what we're doing well, while addressing the high costs of care, which we know Vermonters are struggling to pay year after year. That's why I see so much promise in accountable care, to address costs by improving quality and efficiency. To me, the concept of accountable care is pretty straightforward. The network of doctors, hospitals, and health centers have agreed to be paid based on the quality of the care they provide instead of the quantity. The challenge is really changing the way we pay for something that's 20% of our state's economy without making it harder to access care, adding new costs, or reducing quality. But the early results are giving me reason to be cautiously optimistic. In the 2018 Medicaid ACO program, a group of providers were paid differently than the fee-for-service model that we were using. These providers reduced healthcare services by $7.7 million. In that same year, the providers who were not paid differently spent $1.5 million more than expected. Early results for 2019 show a similar pattern. But we know the numbers don't always tell the full story. And there are some real-life examples of how we can improve care and reduce costs. I detailed one of them in my budget address last week, and here's another one I heard at a similar breakfast a year or so ago. Now, pay attention, because this gets a little complicated, at least it did for me. I had trouble following it at first. I had to reread it a couple times. But there was a doctor in the ACO, maybe someone who is sitting here in this audience today, who had been treating a patient with diabetes and heart disease for several years. Due to uncontrolled glucose levels over many years, this patient required amputation below the left knee and a partial foot amputation on the opposite side. Then this patient needed a knee replacement in their right leg due to a breakdown of the joint. Now, obviously, this required surgery, but because blood sugar levels were too high to safely operate, the surgeon couldn't proceed. But because of the ACO's care coordination model, using resources through the Blueprint for Health and One Care Vermont, this patient received care from a team that included a coordinator, a dietitian, and a physical therapist, all through their primary care office. Together, this team implemented a plan to get the patient's blood sugar under control, which led to the patient changing their diet and ultimately succeeding in getting their diabetes under control, which allowed for the knee replacement. This approach helped the patient take an active role in their own health, maintain their independence, and in doing so, reduce healthcare costs and the costs of other social services. So, due to stories like this and the promising results we're seeing, I've recommended in my budget we continue to support the transformation that's already underway. But there's clearly much more work to prove that payment reform and accountable care are the best path to more affordable and higher quality care. So I thank you for being here. I thank you again for having me and all you do to keep us healthy. I look forward to this discussion from this well-qualified panel and look forward to learning along with everyone else. So thank you very much.
Thanks again, Governor Scott. So now it's my great pleasure to introduce, or to many of you reintroduce, our keynote speaker, Dr. Josh Sharfstein. Dr. Sharfstein actually is a pediatrician by training, and he's currently professor of the practice of health policy and management at the Johns Hopkins School of Public Health. Josh actually served as the health secretary of the state of Maryland from 2011 to 2014, and in that role he guided the process to develop that state's all-payer model. It's really great to have Josh here with his national perspective to put into that national perspective thoughts about what we're doing with our reform efforts here in Vermont. I'm looking for you, Josh. There you are. Thank you.
Excellent. Good morning, everybody. That's pretty good for this early. And let me just say, first of all, I really appreciate your remarks, Governor Scott. I've worked in Maryland for many, many years. I have never seen a 7 a.m. breakfast meeting like this in Annapolis, not once. So it speaks extremely well for Vermont. I'm really excited to help moderate this discussion with such an incredible lineup of people. So I'm going to go pretty quickly through this. Just a little bit of an overview of what's happening nationally and Vermont. And then I'm going to start some questions with some of the great people here, and I'll briefly introduce them. I may be the person who knows them least in the room, but I'm going to briefly introduce them and as we get going, and then we'll turn to questions from the audience. So please think about questions, and we'll try to get in as many as we can. This is me. I also served, I'll just mention, as the City Health Commissioner of Baltimore, so most of my career has been in public health, even though I'm a pediatrician, and I do some work out of a group in New York, which brings me up to Vermont for the University of Vermont Health Network. So I'm going to do these four things: a little bit about the national context, talk about the Vermont model, some discussion of early results, and some key challenges for the state. So the national context. This is about cost. The United States pretty much is number one in cost and pulling away from the pack. Just a tremendous amount of expenditure, about $3.5 trillion for healthcare in the United States, and way more than other countries, and getting even more than other countries over time. And at the same time, U.S. life expectancy hasn't been doing so well. There was just news today that there's a tiny little tick up in 0.1 years. We're still not where we were in 2015, but we had a 3-year decline, which was the first time since the great influenza and World War I in a century. So it's a little bit of good news. I do think there are things that can be done to improve life expectancy, but the country is not in a good place. And in fact, if you look at our life expectancy compared to the rest of the world, we're somewhere around 40th, and there was just a paper that we're going to be 64th in the world pretty soon. So we are doing so well in terms of spending a lot of money, but not so well in terms of living longer. And this actually graphs life expectancy and health expenditure on the same graph, and all the other countries are kind of together, and the United States is way out there because we're so much more expensive and our life expectancy is lower. So that is the national challenge, not just to control costs, but to get more for the money that we're spending in terms of health. Why does the United States pay so much for healthcare and get so little health? So one of the reasons, there are a number of reasons, one of the reasons is the way we pay for healthcare in this country is broken. And the fee-for-service system, where you only get paid if you do something to someone as a doctor, incentivizes expensive procedures even when they're not necessary. It creates a tug-of-war between insurers and clinicians, where the clinicians want to do something, the insurers are hiring people to try to tell them no, the doctors are complaining, which is very inefficient. And it actually rewards healthcare systems when their population is sicker, rather than rewarding them when their population is healthier. It penalizes healthcare systems in areas where people are, it particularly penalizes investments that the healthcare system might make to improve the health of the population. Now, this has been something that has interested me for a long time. It was one of the major reasons for our reform in Maryland. And I tried to find ways to talk about it, and it wasn't always easy. There was one time I got invited to the ecumenical group of Baltimore to talk to them. I never met with them when I was health commissioner. They were kind of a county group. I didn't know what I was doing. I showed up late, and I realized the ecumenical had meant something religious. And I walked in, and there were about 10 men in very serious formal clerical attire, and I had the impression that I was walking into church late because I was late for the meeting, and they all looked at me kind of harshly, and I just was like, right off the bat, I wasn't in a good position. And they were asking me all kinds of questions about the Affordable Care Act, and they weren't giving me a lot of response and I was getting more and more nervous, and I was just talking, and finally they said, why is healthcare so expensive? And I said, well, we there's smoking and there's obesity, but the truth is smoking's going down and cardiovascular risk factors are actually going down. I was just sort of jabbering. And finally I said, it's a lot to do with how we pay for healthcare. If we pay for every procedure, we get a lot of procedures that aren't necessary, and they're very, very expensive. It'd be as if each of you were paid by the prayer. And at that moment, there was silence in the room, and my career flashed before my eyes. I tried to imagine explaining this to Governor O'Malley, and right across the table there was one of the ministers, and he had, a thin face, a pointy nose, and my recollection, he might have even been wearing a cape, but maybe not. That's just sort of my recollection. And he looked at me, and he leaned forward. He put his hand on my hand, bowed his head slightly, and said, "Let us pray." That is absolutely true. So they understood right away, if you pay for something, you get more of it, and that doesn't necessarily work for health. So the idea in health is to pay differently. And there are different ways to pay differently. There are all kinds of charts that you could show how to pay differently. And one of the ways is you say, well, if this is high quality, I'll give you a little extra more. That's sort of one generation. But then you go up to different ways to paying differently. And ultimately, you get to the point where you say, we're going to give a certain amount of money to the healthcare system, and we expect you to use that money and no more, and we expect you to deliver better health outcomes, and the healthcare system organizes to do better. That's the principle. And accountable care organizations are one way for that to execute that vision. We have there are other ways. In Maryland, we do something called global budgeting for hospitals, but it's the same basic concept. For accountable care organizations, a group of healthcare providers, including both doctors and hospitals and others, many others, work together to provide high-quality coordinated care, and they can actually earn more if the quality is good and the costs are below expected and the outcomes are better. But the group can also be penalized. And they can contract with Medicare, Medicaid, and private insurance. That's the concept of an accountable care organization. And what do they do to save money? What is the actual, you look under the hood for an accountable care organization, what's there? And there are a bunch of things. This is a graph that talks about all the different things that they can do. In my mind, the most important thing that they can do is change how care is delivered. They can say, we're not paid now by the heart attack and the stroke and the heart operation. We actually have a chance to do things differently, to invest in prevention, different kinds of things that we'll be talking about, and still see the benefits. In most of healthcare, if you do something to keep someone from having an expensive admission, you're losing the money and someone else is saving it. But when you have an accountable care organization, you keep the money. It's an incentive to change the way care is delivered. What is the evidence so far nationally? These are some just generalizations for accountable care organizations. So you pay people differently. They go out, some of them that work, some of them that don't. Why does some work and some don't work? There are a bunch of reasons, like everything, but one of the key reasons is, well, I'll tell you here are 3 reasons. One of them is strong leadership is very important because you've got to change people's attitude about healthcare. One of them is you have to invest in transformation. You actually have to set up structures that are going to take care of patients differently. But I want to draw your attention to the third one, which is the one I was going to mention before, which is that it works better if multiple payers are involved. Now imagine that you're a doctor, you have 100 patients, and 90 patients you're paid fee-for-service, and 10 patients you're in accountable care, and people are coming around saying, keep those 10 patients healthier. Well, you can't go out and hire an extra nurse to really keep all your patients healthy because you'll lose money on 90 and you'll only do better on 10. So if you get that, instead of that one insurance company for the 10 patients, they work with Medicare, that gets you another 30. They work with Medicaid, that gets you another 20. You get Blue Cross on board, and pretty soon you're talking like, okay, my entire incentives have changed. I can actually change the way I provide care. That's why people think multi-payer involvement is going to be more effective for changing care because it's a more consistent set of incentives. So that's just a bit of background, and now I'll switch to the Vermont model, checking my time here. Got this beautiful, I found all kind of interesting Vermont Instagram feeds from the state of Vermont. I pulled this off of the state parks of Vermont. I almost didn't finish this presentation because I was just clicking through the pictures. So big picture, as you heard from the governor, Vermont is above average in a lot of ways. This is from the Commonwealth Fund comparison of states. You're above average in your overall rank for your healthcare system, access and affordability, prevention and treatment, avoidable hospital use, healthy lives, disparities. It's pretty good. Not all states are above average, I can promise you. But unfortunately, you're also above average in cost, as was also mentioned. This is from the Kaiser Family Foundation, and it tracks the U.S. costs, which is the darker line, and the Vermont costs. So we have this kind of dual challenge we're thinking about. There's still a lot of health to be gained in Vermont. You know, just in the United States, every place we can get more health, and particularly we need to control costs. So there have been a lot, reform doesn't happen overnight, and it builds on prior reforms. So when I look at like Maryland's recent reform around global budgeting, it builds on rate setting that we've had for hospitals for 40 years. In Vermont, you've had a number of really important efforts over the years that create the conversation and the conditions that allow for more substantial change. These include the medical home, the state innovation model grant, the blueprint for health. And then you get, the all-payer ACO model, which came about a couple years ago. These are some of the headlines for it. What is it? It is basically an agreement between the state and the federal government to control costs and improve care by switching to, by establishing a statewide accountable care organization, which we know now is OneCare, and having patients participate in it so that they get enough of the volume, you get that multi-payer involvement, it can actually transform care. That's the concept. It includes a cap of the amount of money that can be spent on healthcare in the state of Vermont, which was the second statewide cap after Maryland. But it has other goals, including improved health and improved quality of care. In many ways, it's a more sophisticated approach than Maryland. The performance period started January 1st, 2017, and ends December 31st, 2022. And so it's a single accountable care organization for Medicare, Medicaid, and private insurers. So it's really trying to create that not just 10 patients, but get to enough patients that suddenly the clinical system can say it's in our interest to do things fundamentally differently. So let's talk about the early results. How do you think about the results for a system like this? I think you have to think big picture, process and outcomes. Process, to me, is, are things being done differently? If you look and everything's being done the same, then you're suspicious right off the bat that this isn't working. So that's the first question. And then outcomes. What do you see on quality? What do you see on costs? And what do you see on health? You want to see overall health improvements too. So for process, and I picked up, I looked at some of the different presentations that have been given, and I kind of picked ones that kind of interested me, the slides. For process, I'm impressed that there are a lot of different process innovations happening in Vermont, from telehealth to care models that really focus on children with developmental issues, the use of innovative technology. And the biggest one has been an investment in care coordination with a 6-fold increase in the number of patients who are actively managed, meaning they have somebody who's looking out for them. I mean, the U.S. healthcare system, patients with multiple illnesses can be essentially pinballs going from one place to another, one doctor to another, and nobody helping them. Anyone who knows anyone who's been sick in most parts of the country, that is the experience you have, my own family not excluded. But a care manager, the goal is to really help make that a lot easier and get people to the care they need to stay healthy and the right care when they get sick. And to really see an enormous increase in care management is a good process outcome. There are others, but I'm just giving you a little bit of the highlights. Quality, I looked it up. You're getting like 82, 85, 86% of the available points. I'm not sure exactly what that means. It's better than 70% of the available points, I'm pretty sure. But seriously, there are a number of specific measures that are very promising in this. Timely care, good communication, good coordination, you score very well. I took out a slide which had CMS's quality checklist for the ACO, and it was either above average or average. There were no below averages. High rates of follow-up post-discharge, primary care visits at high risk, high rates, and a personal favorite of mine, better developmental screening in pediatrics, were all particularly good. What about costs? So there are a couple ways to think about costs. One way to think about costs is, well, what did you negotiate and what wound up happening? And so you heard in Medicare, or you may be aware, there was a negotiation and there was shared savings for the ACO, so that you beat the cost estimate. For private insurance, I think they negotiated and the ACO had to pay a little bit of money back. That's how it's supposed to work. You know, the people are at risk. But the best study of this was done in Medicaid. And this was an independent research group. It was published in a peer-reviewed journal, and it actually looked at Medicaid accountable care organizations in 4 states, Vermont just being one of them. Vermont was the only one that really showed significant benefit, the only state in this independent evaluation. About $39 per person per month compared to the comparison group, and fewer hospitalizations versus the comparison group. The other states didn't show that. And when they asked why Vermont, they dug into it. I would encourage you to read the paper. You see at the top, Vermont had the most promising results. Vermont aligned its Medicaid ACO design with Medicare and commercial ACOs in the state. What has made Vermont successful to date, in part, I believe, is the alignment that I was talking about before and that you see up here, that it's not just Medicaid off on its own trying to be the 10%, saving money, but Medicaid working hand in hand with other payers to get a care transformation that keeps people healthier and makes healthcare more organized for them. And then you can start to see that in some of the things that OneCare puts forward. These are just things that caught my attention, that in Berlin, you see patients with diabetes actually getting their sugar measured, the appropriate way much more frequently. In Brattleboro, inpatient admissions with high-risk Medicare beneficiaries are going down as the number of number of people getting care coordination goes up. These are the kinds of things that you want to see, that you're doing something and you're getting a result for it. And I think when they can do that, to me, it is a positive early sign. It is not mission accomplished. I don't think there's anyone who would say it's mission accomplished, but a very positive early sign. Now, I just want to mention overall population health. The Vermont model is the only one in the country that started out and said, we want to see overall health in the state of Vermont improve as a result of this. It's very ambitious. And they particularly called out drug overdose and suicide, where Vermont is in the 19th to 21st, so on the high end, but not the tippy top of the country. CMS is tracking that. That is actually part of the agreement that the state has to improve the health of the population. And that has spurred different innovations in care. Obviously, it has to work hand in glove with the state. I see Dr. Levine here. To figure out how to improve these metrics. But for example, I've had the chance to visit Burlington and see that in the emergency department, they are able to start anybody on drug treatment, effective drug treatment for opioid addiction right there. And that is associated with a dramatic improvement in people staying in care, which is associated with a dramatic reduction, more than 50%, of people dying of overdose. So the health system can wake up and say, wait a second, we're being measured in part by whether people are dying of overdose. Well, are we providing the treatment that people need right when they come in, and suddenly do that? It's one of the only hospitals in the country that's doing that. So finally, a few challenges. This was my best challenges slide. This would be very challenging for me. Maybe you all look at this and go, that's not that challenging. But for me, it's pretty challenging. I saw that and I thought challenges. Okay, so I want to mention 2 challenges. One of them I've already kind of talked a little bit about is scale. It's really important to get enough patients in an accountable care organization so it can transform care. And we had some goals with CMS for Vermont did for how many patients overall, how many patients in Medicare should be part of the ACO. And you're getting there, but we're still lagging behind a little bit. And so it's actually picking up now, particularly with the private employers coming in. I think the goal had been to be at about 75% for Medicare, and you're about 50%. The goal had been about 50% for the state, and you're maybe a little bit over 30%. So it's not quite what was anticipated. It's very important, though, because otherwise you wind up with I I couldn't find the 1 foot in 2 canoes. I don't know whether that's a metaphor that really resonates or not, but we use it all the time outside Vermont. You know, if you have 1 foot in each canoe, you're trying to do the old way and the new way at the same time. It can be very hard to transform clinically. So that's one clear challenge. The second challenge I would describe as regulatory alignment, and this is what I mean. You have a whole host of approaches to regulating healthcare that have grown up over time, and they get incorporated in law and regulation, and then you completely change the way you pay healthcare providers. Some of them don't really line up, and some of them are just hard to reconcile with each other just because there's so many of them. So there's one point in the year you've got to figure out hospital budgets, another part hospital rates that they charge, another part the ACO rate. And I think it's important to take a step back and say, what are we trying to accomplish? Let's align our regulatory process to accomplish it. In my mind, as you get more scale in an accountable care organization, the most important thing is regulating that accountable care organization because you're setting the overall cost. And some of the other things are a little bit more details. And that should really drive the overall approach to oversight of healthcare, perhaps more than it does now, where you have all of these legacy systems. I'll just tell you, in Maryland, we had, as an example, we had to get people to see differently. We give a certain budget to each hospital. If the number of admissions goes down because people are going out and doing care coordination, preventing admissions, then the price of each admission goes up, but the budget's still the same. So people have to say, like, I'm not going to worry so much about the cost of each admission because we're controlling the overall cost. You know, the important thing is to control the overall cost. And actually, when an individual admission price goes up, that's because the hospital is using that difference to invest in health. That's what we want to see. It's counterintuitive to years of rate regulation where you're just trying to keep the prices down. But since you're putting your hands around the whole thing, it's different. So my point is just that there's a moment here, I think, as this really starts to pick up scale, to be thinking differently and in a way really ahead of other states about how to oversee healthcare. So my conclusions, Vermont, in my opinion, is really at the forefront of the country in paying differently for healthcare in order to achieve better health, lower costs. The early results are solid, in my opinion, with room for improvement and major change you'll see with time as systems really can transform and you get the scale you need. I think that success also requires the commitment and engagement of a broad set of public and private partners. And you know, if you can get this many public and private partners to a breakfast at 7 a.m., I would say you are well on your way to that. So it's a real pleasure for me to be here, and maybe now I will turn to some questions, if that's okay for this group. Thank you very much. And what I'm going to do, like I said before, I'm going to start with some questions to this fantastic panel here, and then we will open it up. I think I'm going to start first with Dr. Sadkin. You're both a doctor and you've taught an independent physician in the state of Vermont, and you've worked with many other independent physicians in the state of Vermont. And my question for you is, you know, that process question. For this model to be effective, it has to actually be doing things differently. What is your perspective on whether it's doing things differently, and could you give some examples?
I think for us, each of our offices is always looking to do something new and different. In particular, I think our St. Albans office is often looked at as sort of like our test kitchen. And so for us, having the opportunity to be part of something like OneCare has been really a great chance because it gives us the opportunity to kind of shift our thinking away from fee-for-service, as you were describing, and gives us a chance to take some new approaches to how we might be able to work towards that goal of really improving the health of the population, really getting our patients much more engaged and involved in their own health care, as you were describing. And through OneCare, we've had an opportunity to take part in some pilot projects, specifically for independent primary care practices. And so an example of one thing that we've tried is doing a diabetic group visit. And I think hopefully you'll hear from one of our patients, Marie, who's part of our diabetic group. But what we decided to try is to, once a month, instead of booking a whole afternoon with individual visits, for that afternoon, we do just a diabetic group visit. And that group is facilitated by a physician, so I do that with the group. And we have our community health team, nurse coordinator, care coordinator, as you were describing. And then periodically, we would also have a dietitian participate in the group. So this group has evolved over time. We are going to go into our third year of it this spring. And the group has been very engaged. It's been interesting. And we've learned along the way. So the newest idea that we had, which I think was kind of like a big forward leap, was to be able to actually put a health coach who's also a dietitian into the group team. And so now, in addition to meeting once a month in the group, the health coach contacts each patient at least weekly in between the monthly group visits. And then what we have found is that the people involved in the group, hopefully you'll be able to say something about it, have been much more engaged in their own health care, and we've seen that they're able to really successfully create and achieve some really personal goals and have really gone a long way in improving their own health.
Great.
So, yeah,
Well,
it's been great.
Thank you for that, and I also thank you for being the setup person for Marie. So Marie said I could call you Marie. That's okay. And maybe could you stand up, Marie, here and come over? I just think I don't know whether people over here are going to be able to see you. Okay. So, you know, this whole system is really supposed to work for people like you. So, you know, give us your experience.
Okay, well, I was diagnosed with diabetes in 2012. Had no idea what I was heading into. Had a strong family history of it, so I knew there were, you know, issues connected with it, stroke, heart attack. So I was seeing Dr. Sadkin pretty regularly. My numbers were going up, not really controlling it very well. So I heard about the group, and I joined the first fall, I believe, of when the group started. Since I've been in that group, my blood sugars, my A1Cs have been fairly stable. Again, it's been a wonderful experience for me. I've changed my lifestyle. I changed how I eat. I'm very cognizant of what is in food now. I really can't say enough about the group. They've really changed the whole picture for me. It's been a wonderful experience. I feel that my health is always being monitored versus going once every 6 months, and it's been a great thing.
And being sick can be pretty isolating.
Yes.
So how's the group experience helped you?
Well, the group experience is great in that when we meet, we all say, you know, like how many times we test in a day and so forth. We bounce ideas off from each other. If somebody's struggling to do something, one of us may say, well, try this. That's helpful. And it's just, we're all in it together. So it's, you know, it's helped us all. And it's been great.
Thank you very much for sharing
Thank you.
that. I appreciate it. I wanted to turn maybe to Jill Olson from the Visiting Nurses Association. You hear this story and you think about the fact that, you know, visiting nurses are just tremendous heroes of the healthcare system.
Absolutely.
And oftentimes, you know, people don't think about them, talk about them, and yet it's work that can be done closer to the patients that can keep them healthy and living the lives that they want to live. How do you see this reform, you know, its importance, and are you starting to see the potential being realized, you know, and when you look forward, what would you like to see?
Yeah. So thank you. You know, it's funny because I heard you say earlier, we're thinking about how we deliver care, and part of what we need to think about is where we deliver care and what care we deliver. So I'm not sure how is even the right word. So I would like to see us deliver more care at home. And one of the challenges that we face right now is that so people want to be home. People do better when they're home, but Medicare is not very supportive of folks being taken care of at home. So they really cut things off pretty early. So we face some regulatory barriers in terms of really being able to provide folks that care where they are. One of the things we're doing under OneCare is implementing what, if any of you have a better name for this, see me afterwards, but we call it the longitudinal care program. And really what that means is that after someone has had a home health episode where they've needed some care at home, what we know and what Judy Peterson's team learned is that often what happens is we see somebody and then we have to discharge them. And we know, the nurse who's been taking care of that person knows they're going to see them again in 6 months after the next hospitalization. And so what can we do to stop those hospitalizations from happening? And what we know is that actually more touch, more patient human interactions with a nurse, with a community health worker over time at home is keeping people out of the hospital in Chittenden County. It's pretty much that simple. People need a lot of support in order to change their behavior. I mean, think about the last time you tried to change your own behavior about how you eat, whether you exercise. We all need a lot of support, and it's no different for people with multiple chronic diseases living at home. And so I really want to see us make this shift, and what's so exciting is that Judy's team was able to implement this program in Chittenden County, and through OneCare, we're actually going to be implementing it all over the state in many of our agencies. So we're working on that this year. But it's really all about making sure that people have that connection. Now, here's what I worry about. Can I say one more thing? So we've already had a massive transformation in the delivery of care in this state in the long-term care program. So we have shifted over the last decade or so that folks who are clinically appropriate for nursing facility care are actually getting care at home. And in Vermont, we're at about 50-50. So we made a big shift.
That's pretty good. That's pretty good. Maryland, we were like at 90-10 in the wrong direction when I started.
Right. We're at 50-50 now. That was our policy goal, and we've pretty much achieved it. But we have not really always invested in the community providers that make that possible. And so when I think about healthcare reform, I worry that we'll make this shift without fully investing in it. So I think that's just something for us to consider, because we have a model already that we've used, and we need to learn from that as we go forward.
Great, thank you. I wanted to turn to Tom Clavel and the voice of an employer here. I know that you're part of the Vermont Business Roundtable that has heard about this and is increasingly involved in OneCare, and I know your own construction business has now just gotten into OneCare. And when you think about the challenges of both cost and health, what does that mean to you as an employer?
Well, let me start by saying I am in the construction business, but a lot of days I do feel like I'm in the health insurance business, which is a good thing. The health insurance and health costs outside of our payroll is really the largest overhead expense we have within our company. And that's strictly from a financial point of view. Our health of our employees is maybe the most intangible asset as a company that we have, because without healthy employees, we can't do our work. But as an employer, you also feel like you are out of the system. We as a company, and I think a lot of employers in Vermont spend a lot of time working on wellness, working on well-being. We spend a lot of time, effort, trying to engage our employees in living a healthy lifestyle, which is great, and we've seen some incredible results. But a lot of times you feel like you're on the outside of that. You can only do so much.
You're swimming upstream.
You're swimming upstream, and you're hoping that the other 90% of the time, or 60% of whatever it is, that they are not involved with us, that what they are doing in their personal lives, whether it's within a healthcare setting or their lifestyle that they're complementing each other. So, and I'm a big believer that in the state of Vermont, scale is critical. And I not just in healthcare, I feel that's critical in a number of things. We just don't have the resources to deal with some of the challenges we have. And healthcare is maybe the most critical one, especially from an employer's perspective, because we support so much of it.
Right.
And it is, it is the number one benefit that our employees have.
So as you hear,
Hands down.
about OneCare, what are your thoughts?
Well, it was interesting when I remember asking, I think it was Don George at the last time you spoke, and I said, as an employer, I can't paint OneCare because I'm not quite sure as an employer how I fit into it. And Don made it very simple. He said, you may not even notice the difference, except you will end up with healthier employers, healthier employees, being taken care of in a better environment. So for me, that was an easy sell. I said I'd be crazy not to participate in the new system. Again, we're fairly new to it, so it's hard to say the benefits we've seen from it or whatever. But I just think for healthcare, for our employees, and let's face it, the challenge of holding on to an employee, the challenge of employees getting older, it just becomes more and more of a risk that an employer takes on.
Right.
I mean, business is risky enough without having to worry about the health of your employees.
And rather than trying to do it all on your own, this is an opportunity to have a state, bring all these different partners together to try to improve health.
You have to, because we can only do so much, and I think having that structure of working together so that when your employees are not at work, that there is a model that's helping them continue whatever efforts we're doing as an employer to increase well-being.
Great. I wanted to go to Mr. George, because you were name checked there. What is your experience? What is your experience with private employers, and how do you talk about this with them?
Well, I think Tom said it well. He's in the construction business, but many days he gets up and he feels like he's in the healthcare coverage business for his employees. And I think that among the 3,000 small businesses in Vermont that Blue Cross provides coverage for, I think that they probably would think ultimately the same way. So we have a responsibility as a Vermont healthcare company to be on a path to affordability on behalf of all of those customers. And we absolutely feel that the all-payer model, the healthcare reforms of Vermont, the integrated system through OneCare Vermont is that best path for the state of Vermont. So for the 200,000 Vermonters that we provide coverage for, we have set up programs with OneCare Vermont, whether they be individual purchasers, small business owners, or large self-insured employers like Tom and Engelberth Construction. They have opportunity to be in the OneCare model. And they're in there because we have chosen, instead of paying fee-for-service, paying individual fees for every piece or service that they receive from a healthcare system, we're paying on a value basis, which means we're either paying a global amount or we're paying a set amount rather than a fee increase to OneCare Vermont in order to be able to provide care coordination, to provide preventative services, to provide valuable care in the different way that, frankly, all of you want to receive it and that they want to provide that care. We know that this is ultimately, for the reasons that Tom gave, is best for those that we provide coverage to. But also because Medicare and Medicaid are in, as Tom said, it's a small state. So having one accountable care organization does make sense to me. And ultimately having all of the payers in together into relatively the same model in providing that scale is absolutely necessary. We think that Blue Cross Blue Shield of Vermont's customers are absolutely better off because Medicare and Medicaid are joining in the same model. And we think we have a responsibility as a Vermont organization to be about Vermont and to be in this with our customers because ultimately it makes things better for Medicare and Medicaid.
Right. Thank you. Thank you very much. Now, I wanted to turn to Mike Fisher, the Chief Healthcare Advocate. Your office has a really important role because, you're hearing directly from people who are having all kinds of challenges with the healthcare system. You're also thinking about policy that can fix some of those challenges. We were talking before about some very interesting work that you're doing. You have a background as a social worker as well as a state legislator. I'd like you to share maybe a couple concerns that you have about the system as well as a couple hopes that you have for this change in Vermont.
Yes, thank you. Good morning. I'll start with the hopes, and thanks for recognizing my social work background. I think it's really important for us to recognize that much of this effort builds on a long history in Vermont of community efforts to coordinate care. Communities have been, digging in and doing that work on the local level for years and years, and saving a lot of healthcare dollars, not in such a coordinated way. So I am, of course, supportive of the effort to improve that and to bring some new funding resources to some of that effort. I would share one of Jill's concerns about whether it's enough investment and whether it's a sustainable investment. This is a big culture change we're contemplating here, and I have expressed and will express whether it's enough of an investment to really bring about the change we're talking about. I wouldn't be the healthcare advocate if I didn't mention consumer affordability, and I don't want to bring it up in the sort of the vague way of people can't afford things. I want to bring it up in a little bit more of the specific concern of when people make economic choices over their healthcare choices that push in the wrong direction. And we do have a low uninsured rate, and that's great, but we have a sort of impressively growing rate of underinsured. That is, people who have high out-of-pocket costs given their incomes. And I can't put it better than I think I'll read just two comments from Vermonters who recently said, one said, despite the fact that I have employer-provided insurance and I pay a premium, I still can't afford to go to the doctor. Another said, the high cost of insurance combined with the lack of adequate coverage has resulted in us skipping annual physicals and largely avoiding the healthcare system. So I bring that up because I think we need to recognize it as a substantial risk to the success of this effort. And so I think that would be my chief concern to bring up.
I think those are very important things to raise, and I think they point out that you have this one side of things, which is trying to change the way care is delivered, but there's the other side of it, which is how patients experience it and what their particular costs are for engaging. And those costs will look different in part based on the plan they're in and all the different different variations that exist. There are some states that are, I'll just mention, thinking a little bit more about insurance design and how to make sure people can get to their annual physical. For example, Medicare, I don't think charges for the annual physical now. So those sorts of things can complement delivery system reform. I wanted to, I'm almost ready to take questions from everyone, but just a couple more queries to this amazing panel here. I wanted to turn to Professor Holmes, who is at Middlebury and the Green Mountain Care Board. And, this is a big endeavor for the state and a lot of responsibility for the Green Mountain Care Board. You've got to make sure that it's on track. How do you think about the short term, is it on track, and the long term, what you're looking for?
Great, that's a great question. So I think that one of the things that I ask people when they ask me about this and the successes short-term and long-term is I ask for patience, and I think you mentioned patience as well. We have become somewhat of an instant gratification society, right? To the degree that I can stream any movie that I want tonight instantly with a click. I can buy anything I want and it's delivered tomorrow. I can swipe right and have a date tonight. I can do anything quickly. we're transforming the payment and delivery system, a very complex payment and delivery system, and that is going to take time. And until we reach scale, we actually can't judge its success fully. So I look for small things that I think are showing us that we're on the right track. And I see that through the Green Mountain Care Board regulates the ACO. We see their budgets. We also regulate all of the hospitals in the state. So we oversee all their budgets. So there's lots of different views. And also to the extent that we regulate insurance, rate review there for large group and the exchange, we see it. We have a lot of different perspectives on the whole system. And the ways in which I see change, first of all, this is a provider-led reform. It's only going to work if our providers in the system see value in this, that they see that they have the flexibility and the financial incentives to care for the patients the way that they want to, with the idea of population health as the main goal. So we're seeing providers voting with their feet. We have 13 out of the 14 hospitals in the model. We have the majority of the FQHCs. We have the majority of the designated agencies, of the skilled nursing facilities. I think we have all of home health agencies in the system. We have over 250 practices, primary care practices in the system. So the providers are voting with their feet. They see value in the model. They see a mechanism through which they can deliver care better to their patients. So that gives me hope. The second sort of view through which I see this is we're seeing the system change its investments. We're seeing hospitals invest differently. Hospitals now, I've been on the board now this is my 6th year. I've seen the hospital budget process over these years. We are now seeing hospitals investing in social workers in their emergency rooms. We're seeing them investing behavioral health specialists and nutritionists in their primary care practices. We're seeing hospitals investing in lifestyle medicine specialists, nutrition specialists. We're seeing hospitals enhance their palliative care in their cardiac rehab. We're seeing them investing in housing in their communities. Right? This is a transformation that I've seen over 5 years. And they're realizing that if they're paid differently and that the goal is to basically align with what patients want, which is lower cost, high quality care, and the incentives are structured that way, the investments are going to be made that way. So seeing those providers start to make those investments gives me hope for the long run. In the short run, we're already seeing through this care coordination model and care managers, we're seeing the traditionally siloed providers breaking down those silos. We're seeing care being coordinated, particularly for the most complex patients. And it's leading to lower ED visits. It's leading to fewer hospitalizations. So we're starting to see in the immediate short run outcomes that we want, lower cost and higher quality care. We're also seeing the power of data analytics. OneCare has built a system where they can start analyzing large population data. They can see variations in care, variations in quality. They can share best practices. They can identify high-risk patients and help their providers intervene earlier in the care of those patients and coordinate that care, and we're seeing some of those outcomes. So those are the ways in which we're already seeing short run, the impacts on patients, and we're seeing the investments that these providers are making that are going to have long-run goals. This is a long game that we're playing. We're trying to reduce obesity rates. We're trying to reduce cardiovascular disease. We're trying to reduce diabetes. That's going to take some time. But the investments are happening now, and the providers and the payers are seeing the value in this model, and that gives me hope.
Great. Since you talked, thank you. And since you mentioned hospitals, I just want to turn to Jeff Tiemann from the Hospital Association here for a second because, if Vermont hospitals are doing things differently than they were before, what I want to know is when your peers, other hospital associations, call you from around the country and they go, what in the world is going on in Vermont? Why are you doing these things? What do you tell them? Why are the hospitals so engaged in this change?
Yeah, great question. And Dr. Sharfstein, I just want to say before I answer that we do a lot of work here in Vermont every day to try to explain what we're doing with this reform effort. And sometimes we're better at it than others. We've used metaphors and analogies and descriptors. And I think you did an outstanding job distilling it and keeping it fairly simple and clear. So nice work. We're gonna pilfer from that. To answer your question about why or what my state counterparts say as I travel around the country and work with the American Hospital Association, which is the national arm of my state-based association, is that the providers, the hospitals in Vermont, really decided to lead the way and jump into this effort for a pretty simple reason, which is the opportunity to really do what this panel, I think, visually represents, which is to come together as a community of providers and really deliver patient care in a more coordinated and thoughtful way that also keeps people healthy. And ultimately, that saves costs, but really, maybe more importantly, it orients our healthcare system to what I think it should be oriented to, which is helping people live longer, healthier, better lives. Instead of just waiting for illness and injury to occur, we will always need to treat illness and injury. But this provides the opportunity to really be focused on health and wellness. And as healthcare providers, that's extremely compelling. From a more practical standpoint, a stable revenue stream that comes as a result of a block payment for caring for a patient population can help insulate against volume fluctuations and other budgetary challenges that hospitals have. And then, so I think those are the sort of compelling reasons. There are obviously challenges, as some of the other panelists have talked about. But I just want to conclude with picking up on what Jessica Holmes said about instant gratification. I worked on the Affordable Care Act many years ago. Hard to believe that's now been over a decade, and we're still trying to defend the thing. But the bottom line is a lot of skepticism was happening in the first years of the Affordable Care Act. People weren't getting enrolled, expectations weren't being met, and those things resolved. Is the ACA perfect? Absolutely not. But 25 million people in this country have coverage who didn't have it before, and for millions of others, it's more affordable than it was before. I think similarly with this, we have to be patient. It will take time. I'm confident it will work, but we have to get through the risks and the challenges and do that together. And I think if we do, we'll be successful.
Thank you. Commissioner Gustafson, thank you for being here. And I wanted just to give you a chance to talk for a minute about the role of Medicaid. I noticed that, Medicaid was early on, an early investor in this idea. And maybe talk about, why that was and what you've seen from the perspective of the Medicaid program.
Well, first of all, thank you for sort of outlining the theory of the case for us. That's seems like an important piece of the conversation because this is so new and fresh to so many in Vermont. The fact that it is a small state, I think we all know each other here, and that we're all here because we probably have meetings right after with each other. So that, I think, has helped a lot. Leadership, you mentioned it. I think leadership is probably one of the biggest reasons that Medicaid has been a leader. I think I've been in this position as commissioner outside of the state, known as Medicaid director, for just over 3 years. And on basically week one of the first things we did was go into the governor's office and say the previous administration signed on to an all-payer model agreement. Are we going to do this? Do you support this? And knowing about all the things you mentioned, cost of health care and the challenges we face demographically and economically in the state, his guidance was, yes, let's proceed. And so from that first sort of moment, we've relied on leaders across the state and across this healthcare system and the payer system as well to execute. And so Medicaid was an early piece of that, kind of the tip of the spear, you could say, I guess, where we said, well, what are the principles? And I think they've all been mentioned here. It's a set price, pay prospectively, creating an opportunity for alignment and an opportunity to change how the healthcare is delivered in the state. I've actually worked in a couple of the organizations that are here represented, and we've all kind of worked together in different ways. But I remember when I was working at the Hospital Association, one of the things that would be said was, great, another state innovation. If you don't have Medicare, don't come talk to us, because that's, again, it's just this fragmentation. And so that fee-for-service incentive is obviously the big problem, but that fragmentation is a secondary problem. And so by having the all-payer agreement and having us be able to engage early and say, look, we're gonna pay prospectively on a set price, and we are going to figure out a way to help get to that scale. It has allowed, I think, the ACO to sort of incrementally get this rolling. And I love the comments about, this is going to take time and patience and evaluation. I think after the first 6 months, we had our first contract. Someone said, "Is it working?" And it's like, we're trying to change a system that has been built over many decades without any plan. And I think true innovation, if you just look at any examples across any environment, any industry, they don't, it doesn't happen all at once. And so.
Still, it's pretty nice to get an article saying Vermont had the best outcomes with the states that have done it.
It
so
is.
far.
I'm not really sure that many people in Vermont paid attention to it. We saw it. We were very proud of it. We put it out there. But it has been a bit of a challenge to both work on it and then tell the story. So it's great that you're here doing this. Thank you.
Okay, great. So I think we had everybody except one person so far has spoken. And I didn't intend for you to be the last one, but let me just say that I think it's good in a way that you were the last one, because sometimes people think of everything being on your shoulders at OneCare, but in fact, it really requires everybody here, people who are representing consumers, people who are working in the delivery system, patients themselves, everybody to get this to work. So I'm just going to ask you a quick question because I want to turn to questions, but when you wake up in the morning as the CEO of OneCare, what's your job? What do you have to do? What are you thinking is the mission?
So thank you for that, and thank you for mentioning just the public-private partnership aspect of things, because I really, truly feel honored. I mean, it is very hard work that we're doing across the state, and it's really important work, too. So I started my career 26 years ago as a nurse, and I did that for a reason. I wanted to help people to be the healthiest person that they could be and to live their life to the fullest. And, when you go into nursing, a lot of the inpatient care is treating sickness and illness, and then you don't get to see how they might flourish after they leave the hospital. So I slowly moved my way into administration, thinking, how could I really improve the health of the populations and really make a difference? And so OneCare Vermont has thousands of providers. I mean, we listed them off here today that have really come together to participate in a pretty large effort to say, okay, we have been freed from the shackles of fee-for-service after decades. Now we have the opportunity to care for people the way that we think is best, and that makes the most sense for them and for us as well. And so we've been able to test amazing innovations that let people get treated in their homes for the longitudinal care project. It allows people to be treated in groups so that they can really build a community around them. And those small tests of change are really what I see as very promising in this effort.
Great. Okay, thank you. Well, now we're going to turn to questions.
Hi, I'm Judy Peterson, president of Home Health and Hospice in Chittenden County.
Okay.
I know end-of-life care is one of the, most costly times in people's life. And in Vermont, our utilization for hospice is actually very low compared to other states. I'm wondering if you or your panelists could comment on that and have any thoughts about how we can turn that around. I really believe as a hospice provider that it is not only a less costly way to provide care to people, but really improves quality of life.
Great. Anybody want to jump that question? I'm happy to give a little answer, but okay, go ahead. Sure.
So I can only relate Blue Cross Blue Shield of Vermont's experience, and that is having personal relationships between patients and case managers. And I think that this goes for OneCare Vermont physician offices as well as Blue Cross Blue Shield of Vermont. We know that ultimately when people are terminally ill, the vast majority of them want to die at home. The reality is the vast majority actually pass in some other facility setting. So all I can relate is through these personal relationships of case management nurses and patients, we've ended up with a higher percentage of Blue Cross Blue Shield people who end up passing at home or in hospice by far than the national average. The only thing that I can attribute it to is what I actually hear from our customers, and that is the personal relationships, the guidance and the counseling that they receive from case management nurses.
Great.
I just had a quick anecdote.
Sure.
So before I was on the Green Mountain Care Board,
speak
closer, sorry. Before I was on the Green Mountain Care Board, I actually sat on the Porter Hospital Board. And when I was on the Porter Hospital Board, at that time, Porter was having some financial difficulties, and palliative care was something that the board decided was not kind of in the financial best interest of the hospital at the time. This was prior to the all-payer model. It was a revenue loser for the hospital. Subsequently, now that the all-payer model is in place and there is a different payment system and a different incentive structure, palliative care is back and being enhanced because it does exactly, it improves patient outcomes, it improves the end-of-life care, and now it's financially more aligned with the model, and there's incentives to do so. So it's interesting that one piece has changed in the last 5 years.
Great. Over here, go ahead.
Hi, I'm Barbara Rachelson, a legislator from Burlington and a social worker. So there's a big risk and worry that I see that hasn't come up this morning. We have a shortage of doctors and other healthcare providers in our state. And in talking to people who chose to go elsewhere, we pay way less than other states. In fact, I just heard from somebody recently they could get 4 times as much in their specialty elsewhere. And we know doctors have huge loans, et cetera. Same thing with nurses and other specialties. So the wait sometimes to get in to see somebody is going to be longer because we don't have the enough of the appropriate medical employers or employees here. So I'm just wondering how we can try to tackle that, because I'm worried it will undo all this great work.
Great. Anybody want to jump in on that?
So I would agree with you. Workforce issues, I think, is both a challenge that we have in Vermont and on a national level as well. And one of the things I think of that will help in this overall model, if you think about the way that practitioners are now paid for, they don't have to have somebody come into the office to have that visit. We have aligned quality metrics, which really reduces the administrative burden, so it can allow clinicians to spend more time with patients and their families. It allows them to deliver care in the way that they want to deliver care. We've done some amazing work in the Medicaid program where we have actually eliminated prior authorization review, which is an extreme administrative burden. So when you think about the overall system and their ability to make that impact in the work that they do every day and feel good about it, that will at least help you to retain your current
Yeah, I want to see what Dr. Sadkin thinks about that
Yeah.
as a physician on in the panel here.
Yeah, it's complicated, right? The whole thing is really, really complicated, and I completely appreciate what you're saying. I mean, I know in independent practices, we have found it pretty much next to impossible to recruit any new physicians. We can sometimes successfully recruit some PAs and nurse practitioners, but we're not able to recruit physicians. So you can't recruit them, then we cannot retain them. We definitely have an aging workforce as far as our primary care physician population, and we need to start planning for that. So something that we think about all the time, every single day. But I think it is going to take some brainstorming and some real collaboration to figure this out, because we need to put investment. It goes to what other people were saying before. This is a marathon, not a sprint. It is going to take a long time to really see this through to real change in the population health. But the way to get there is a complex pathway.
Do you see some value for some of these things on burnout, which is a big problem in a lot of places around the country? I mean, that physicians start, maybe they get a big paycheck, but then a few years in, they don't want to keep going. And, you know, part of the promise, I think, of doing things differently is people enjoy their work more.
And what I'm thinking is, what we think about all the time is really placing the investment in the foundation. We've talked for many, many years that primary care is the foundation of all of these things being successful, and yet we really have not put the investment into making that a reality and a possibility. So I think together we all have to figure that out so that we can really achieve the goal that we're looking towards.
I just wanted to comment, we also need a lot of nurses in this state, 5,000 of them in April. So if you know anybody, send them our way. But one of the things that we did over the summer was the Rural Health Services Task Force was convened by the legislature last year and spent a lot of time coming up with what I think is one of the most concrete pieces of work I've seen come out of a task force in my career, and it's now making its way through the State House with a number of very specific, concrete recommendations for how to improve workforce. And I want to acknowledge also the governor, who has really made workforce top priority for his administration, which we are deeply appreciative of. I think it is absolutely the underpinnings of the success of whether or not we're able to make this work.
I wanted to add something really quickly. And when I say primary care, I just want to be clear that I don't mean only physicians, because to really do this healthcare transformation, what we need is a lot more support staff. So not only physicians, but nurses, social workers, dietitians, health coaches. It's the whole package.
Great. Who has the mic next? Yeah, go ahead.
Hi, I'm Debbie Ingram. I'm a state senator from Chittenden County. And I'd like to get back to the costs for the consumer of our healthcare system. When I talk to my constituents, and based on my experience as an executive director of a small nonprofit, their concern, our concern is, will there ever be a time when lower healthcare costs translates into lower premiums in our insurance plans? My experience with my nonprofit is we were offering the platinum plan to our employees, and that was costing us $786 per person per month, which I think is already very high. But this year it went up to $900 per person per month, and I actually had to make the decision to downgrade the plan because we just couldn't afford it. So when we're talking about alignment, what needs to happen in lowering healthcare costs for our insurance premiums to also go down?
I think that's a great question, and certainly your experience is not unlike the experience of many small business and organization leaders around the country. I mean, there's just a lot of cost pressure. The cost pressure that exists, and certainly the level of cost is related a lot to things like the salaries that doctors earn and just the prices in the U.S. healthcare system. So then what OneCare is trying, and what this initiative is trying to do, is to transform the work inside the healthcare system to get better outcomes and a lower cost increase over time, but it's not designed to yank out a huge amount of expense right away. I think the way I think about your question, and I'm going to pose it here, is how do you make sure that the gains that you see in the studies, even if it's not, suddenly everything's 50% the cost, but it's that costs are growing more slowly. How do you make sure that those things really do reach the consumer? And I think this relates in part to the point that I made about regulatory alignment. Like, if you have the base, like, look, if we're only paying a certain amount for healthcare to the ACO and people are really in it, then we should be seeing over time that the premiums and the expenditures are for the individual are really linked to that, and they're not going all over the place or don't have any relationship. And as you're regulating the rates of insurance companies, that should be linked to this so that the savings can get translated. Now, that would be partly my answer. I'm happy to see whether people may disagree with me or see that differently, or how you see the translation from the savings that are potential here into the premiums that wind up getting charged in the private market. So that's certainly a good question for you, Mr. George. But if there are others, maybe Mr. Fisher, that want to take that on briefly so we can get some more questions in.
Well, thank you, Senator Ingram. It's a great question. So there is a direct relationship between the costs that we all incur in the healthcare system and the premiums that are charged. A couple of years ago, when Blue Cross Blue Shield had a relatively large increase for those individuals and small businesses on the Vermont Health Connect market, I did say it is because the consumption of all of us of healthcare services that we ask of hospitals and doctors in Vermont is going up. And so to the extent that we control those costs, there will be a one-to-one relationship of those costs in the premiums in the future. As a Vermont company, Blue Cross Blue Shield of Vermont has an administrative cost of about 6%, compares very favorably to a national average of 10 to 12%. So about 93, 94% of every dollar that people pay to their premiums is going to pay for health care services. As a Vermont company, we're going to pass on all the savings that we generate from work with OneCare to the 200,000 Vermonters we provide coverage to. You can trust in that. Even if you were skeptical about trusting in that. We have the Green Mountain Care Board, and we do a 6-hour hearing. Michael Fisher represents consumers in that hearing. There is a very thorough process to ensure that when I say you can trust in this, you can actually trust in this. If I could just 1 minute more, I would say there is one thing that the cost of our healthcare system that is out of our control for all of us here in this room, and that is the high cost that U.S. drug manufacturers are charging for prescription drugs. The high rate that Blue Cross Blue Shield charged in the individual small group marketplace a couple of years ago, there was 8 points of that increase that was the result solely of U.S. drug manufacturer price increases. We put no government constraints at a federal level on that. We're the only of 35 industrialized countries that do not do that. We need to have drug price controls at a federal level to be able to get at that. I would say that it is the lack of those federal drug controls that caused Blue Cross Blue Shield of Vermont to take the unprecedented step of investing with other Blue plans as founding partners in a not-for-profit drug manufacturer, Civica. The reason we do this is because Civica is a not-for-profit drug manufacturer, is going to produce generic drugs that are currently only produced by sole source drug manufacturers, and they are charging egregiously high prices for these, particularly for these specialty drugs. So by joining and investing in a not-for-profit, we intend to disrupt the for-profit supply of drugs that are coming to the marketplace that are prohibitively high.
I'm familiar with that effort. I did not know that you're an investor. Mr. Fisher, quick comment.
So just briefly, thank you for the question, Senator Ingram. I think I do want to say that I know that there are many people who either celebrate or criticize this effort based on the $1 or $3 million savings or losses, from year to year. And from my perspective, I do want to say out loud that we're off $1 to $3 million or more in our projections anyway, before the effort of OneCare. So, seeing a year-to-year change that goes up or down a little bit doesn't give me particular hope or particular fear. We're looking for trend, and I agree with the panel that it takes more time to determine trend. But I also do want to echo, your expression of concern. This is where I get called impatient, because consumers out there are impatient, and consumers out there and small businesses out there are saying, we don't know how we survive this year, and that sort of goes back to this is a very tough environment to be successful in an effort like this.
But, thank you. And I think it's important to say that the agreement that the state has reached with the federal government is to actually grow slower in healthcare than essentially the projected growth of the economy. But that is still, an increase. And so, this is, I think, misunderstood if it's thought of as an effort to just drastically lower the costs of healthcare in the short term. There are ways to help people afford the cost of healthcare, but really this is a way to make healthcare more sustainable and to improve health at the same time. So it's just important to have, align the right set of expectations for this particular kind of change. Okay, who is next? Yes.
Hi, I'm Mark Crow. I'm president of 10th Crow Creative. We're a brand and marketing agency that works in the health and wellness area, and I'm also a member of the Vermont Business Roundtable. Given all the recent news about various hospitals being in the red, it does feel like we are definitely standing in two canoes right now, and I'm assuming some of that redness is due to this transformation. I'm sure there's other reasons too. My question or questions relate to scale. One is what's being done these days and what's projected to be done to increase scale. Two, I'm curious what sort of resistance you're hearing about those who don't want to become part of OneCare. And three, how is scale defined? What is that number that we're going to be comfortable in reaching and feeling confident about it? Thank you.
Great. Maybe Jeff Tiemann, if you want to speak for a second about that question about how hospitals are doing, and would it help hospitals for more scale at this point?
Yeah, I mean, I think for all the reasons that have been stated, scale is hugely important here and sort of a fundamental piece of the model. But to the question that was asked, half of Vermont's hospitals are posting negative margins and are struggling financially to varying degrees and in various ways, and really for various reasons. So I don't think it's at all fair to say that it's because of investments in the all-payer model that they're struggling, although that does certainly put pressure on especially the smaller hospitals that don't necessarily have a really strong balance sheet to manage what is essentially new financial risk that hospitals are taking on in this space and in order to participate effectively in the model. So I think that piece of the answer, I'll let the experts on attribution speak to scale, but I think on this piece of the answer with small hospitals and really all hospitals in Vermont, because this is hard work for all of them, we do have to figure out ways together with the federal government and our state partners to mitigate and manage the new risk that is associated with being part of this and making the right investments in social determinants and all the things we need to do.
But it's also the case that if you have more scale, then that dependable chunk of funding gets bigger for hospitals, and it makes it a little bit easier. Commissioner Gustafson?
Yeah, I can speak to what's being done. It's a good question, what's being done in terms of getting greater scale. So the first few years of our contracts, we took Medicaid-eligible members who had relationships with their primary care physicians, and over an extended period of time, if they had claims, they were in the model and were appropriate to be attributed lives to the ACO and to their providers. And for 2020, we've expanded the eligible groups that would be attributed by finding basically people who didn't have either claims in the system that fit the previous attribution model, the traditional we call it, which is funny because it's only 3 years old, but it's we've expanded to people that haven't had claims and to people that have a specialist only, and that gets to the model, right? That gets to, hey, there are people out there that aren't getting medical care, they aren't getting wellness visits, they aren't getting coordinated care if they're seeing specialists only. That sort of idea of bouncing around the system and just sort of in and then out, and then we don't see them, and then there's a pretty significant event that needs to be addressed. And so that's on the Medicaid side. OneCare and Medicaid spent a lot of time, just in the last few months, really trying to nail down, because this is the feet and two canoes part. You can pay prospectively and say you're responsible for this entire population, but if some of your payments, and right now we have, let's say 60% are prospective payments geared towards that set price, and then the rest is still fee-for-service. So we still have to figure out what's the proper reimbursement. But in order to get the 60 plus the 40 gets to your agreed-upon cost, well, right now we're using fee-for-service reimbursements as our and previous utilization as our measurement. I mean, that's the evolution. That's what takes time. That's the incremental. And understanding that we're in a rush to change things, we also have to be patient too, and just incrementally. That's been our goal, is incremental. Are we stable? Yep. Okay, it's working. We had a good year in terms of what we were doing. How can we move one more step in the right direction?
Yeah, I know there's going to be a lot more to say, but I want to get some more questions. There are efforts, obviously, with private employers to do reaching out, and with other types of clinicians. But truthfully, I think one of the reasons to have an open conversation like that is for everybody here to appreciate what's going on, because it's through all kinds of conversations and understanding that people can, decide for themselves and talk to people about the value of getting scale with the Vermont model. Maybe we get like one or two quick questions back to back, and then we'll ask them back to back, and then because we're running out of time. Go ahead.
Hi, Jennifer Kyoto from CX Associates, where I'm a small employer in Burlington and struggle with healthcare costs. And one of my concerns is about the Medicaid cost shift and how that impacts my rates, but also how it impacts the ACO and the the ability of the ACO to provide the services.
Got it. And sir, would you like to ask your question now too?
Sure. You spoke of challenges. One of the challenges I've seen for a long time is the realization that our population believes that death is an option. So when you go to measure how, from the public's view of how you're succeeding, realize you've got a bar that's very hard to reach. You are improving dramatically. I would also like to really thank the leaders that are in this room for not only the vision, but actualizing that vision. It takes courage to do that, and you're changing a culture it's tremendous to see this happen. The question is, are the state employees part of the ACO?
Okay, we'll get that. And you look like you're going to jump out of your chair, sir. So I'm going to we'll get the. Why don't you pass the microphone and just we'll get your question. We'll shoehorn it in, and then. Go ahead.
My name is Joe Haddock. I'm a primary care doc in Williston for 42 years.
Okay.
Do you think CMS will do this longer than 5 years?
Okay.
We've changed our practice how we do it, and if we invest in it and change how we do it, and then CMS gives up on the waiver, then it'll be like special education. They required it, paid for it, then they required it and didn't pay for it.
Right.
And that's what our concern is.
Well,
do you think they'll stay on it?
Yeah, I'll give you an answer, which is I think that if you're continuing to move forward like you are, I think they will. In Maryland, we had this question. We did 5 years, totally transform hospital payment, and people were worried what would happen in year 6. And it turned out we had, a different governor's administration, a different president, a different CMS, and we got 8 more years. So, and people were just really positive because the state hung together. We talked about the promise and the challenges, and here's what we want to do in the next phase. So I think there's every reason to be hopeful, at least. I certainly am not going to, give any hard predictions, but I think there's every reason to be hopeful that will be the case. So we had the other 2 questions. I'm just going to maybe if I do not think state employees are in. Is that correct at the moment?
They're not currently.
Yeah, not currently. So that's one answer. And then the other question was about the Medicaid cost shift. I don't know, Commissioner, if you mention it.
Yeah, that's a conversation that comes up a lot. I think when you talk about the cost shift, I don't know that anybody wants to spend more on their Medicaid program. We spend a lot. Understanding that does happen, I think it's really gets to, again, that fee-for-service world. So in healthcare, in a fee-for-service, any business, you have things that cover your costs, things that don't cover your cost. If we can get out of that mentality of how we get this much from these guys and this much from these guys and more into what does it cost to provide healthcare for the entire state, the Vermont and the state of Vermont Medicaid program and the federal government, which are the equal funder, will be willing to pay their fair share, right? That's the sort of idea is look, we all want to contribute to a functional healthcare system.
And there are
addressing
some
purely on
provisions.
the cost shift is a difficult question because you're asking taxpayers to pay more.
Yeah, every state has some degree of differential between what public and Medicaid pays, at least even Maryland for non-hospital costs. But interestingly, the agreement that Vermont has with the federal government has some ways to put a little pressure to narrow that. There are investments that can be made that don't count against the state. There's some very interesting encouragements to the state to do more. And so I think it is actually a framework to get a little bit of progress on what is an issue for pretty much every state.
And I would just make one other quick point. In a world of finite resources, we all have those. We have prioritized primary care spending, so we have matched our payments to primary care physicians
Right.
and primary care services to the Medicare levels. It's something because it's the priority of wellness, and so we do have the opportunity to change exactly, or so in some ways how we pay for things, but the total amount feels a little bit more finite than.
Yeah, what I would say is if you're looking from the private sector at Medicaid and for bringing all of whatever different issues that you have, a good question to ask is the investment in Medicaid moving the healthcare system in the right direction such that it can help us? And that's really what Medicaid has been a critical partner in. All expenditures in the healthcare system should make the system better for everyone. That is the idea of aligning the different payers, that when Medicaid is paying in a different way, the practice is able to do things differently, and you can get, a diabetes group discussion, and, all patients can benefit. So you have a platform in Vermont for that. It doesn't guarantee results, but it gives you a chance that other states do not have to bring the various resources in healthcare and wind up getting a change that really is good for both costs and health. So I think that it's an interesting way to think about, and I haven't thought about it quite that way before, how being multi-payer like you are in Vermont not only gets you those results that only happen in Vermont, but gives you a lot of promise moving forward. So with that, personally, before I go, I just want to say what a pleasure it's been to meet you all today and to be able to moderate with such a great group of people. Thank you for having me.
So thank you so much, Dr. Sharfstein. I do want to comment on the use of the foot and two canoe metaphor. Those of us that are here and in the North Country, we'd never do that. That's not, to get yourself in that situation is not intelligent. I think more that we're in the parking lot, we're heading up the Burroughs Trail, we're heading towards the top of Camel's Hump, and there's definitely twists and turns in the road. There's, in the trail, there's things that we'll discover along the way that we'll stop and that we'll look at. But we know that there is a summit and that there is a path and that we're heading up it. And we did have some themes today. Marathon, not a sprint. Incredibly complex. Unbelievably important for us to stay on that path. And in my 40 years in Vermont, the way we solve complex problems is that we get the right people in the room and we hash it out, we keep working on it until we get it right. And I think we owe a real round of applause to folks with a lot of different perspectives on this who spent their time this morning, and all of you the same way. We thank you for coming and being part of this conversation, and we'll keep on that path and we'll keep moving forward. So thank the panel and thank you all.